Thank you very much, Chairman. It's a great pleasure and honor to be up here, but a difficult task to follow on from two great speakers, but I hope you'll stay with me as I take you through a whistle-stop tour looking at new techniques available in the A500 in high-frequency ultrasound and their clinical applications. We've been fortunate in working with the A500 since its inception, and I'll just like to point out a few nice features when you're in a busy clinic, that it has some very nice new and improved workflow and multi-functionality keys, which unique to Toshiba. Any of these keys can be turned into any function that you like to. So very useful if you want to configure your system into something for you that's easy to use. You'll also notice that the computer speed is markedly increased. But with respect to high-frequency imaging, it is really the 18 megahertz probe that has come to its fore. It's got markedly improved penetration, and the new levels of compounding and precisions of image processing really provides exquisite spatial resolution with no loss of frame rate. And I think this provides a really gold standard B-mode image, and I like to illustrate this by taking you through the course of the median nerve through the forearm, something which can be quite difficult to follow if you don't have very good spatial resolution. Here is the median nerve as it's through the forearm as the video starts, and you can see it's running quite deep here for the moment, but look at the nice detail of the adjacent flexor muscles. And here, as we follow the median nerve through the forearm, as it comes up to the wrist, it becomes more superficial. And as it gets more superficial, the neurofibrillar bundles become more apparent. And here it is just coming up towards the wrist, and you'll see it start to tuck under the flexor retinaculum itself here. So here it is, flexor retinaculum, median nerve, and you can see the good relationship, and you can check to see whether there's any carpal tunnel syndrome with great accuracy. So let's look at some pathology. Turning to musculoskeletal imaging, first of all, where grayscale imaging is really key. Here it is in wide view, and there is no loss of image quality. You can see a ruptured Achilles tendon in plantar flexion. You know immediately that the two ends do not oppose one another, and so this patient needs to go to surgery. Here it is, shown very nicely in panoramic view, and one nice feature it is now in panoramic is that you can actually provide an accurate measurement across there to tell the clinician exactly how wide the gap is. Bread and butter imaging now from a full thickness partial with supraspinatus tendon tear. You can see a large full thickness partial with tear of the supraspinatus tendon going right across it. But one thing as well that you will notice is that you get a very nice outline of the humeral head itself, suggesting that this has been quite a long-standing tear in its own. Here it is, another aspect of musculoskeletal imaging is dynamic movement, assessment with dynamic movement, and there is really no loss of image quality in this shoulder impingement, where we can see, as we look up here, as the shoulder abducts, rocking of the coracoacromial ligament. So very easily you get a good quick diagnosis and accurate diagnosis. Intervention is also very easy. You can actually see your needle tip down to virtually 2 millimeters here within the subacromial subdeltoid bursa. Here's a steroid injection going in. As we inject, the needle is accurately placed, and you can see it shoot through around the subacromial bursa. One other nice feature is looking at grade 1 muscle injuries, which can be difficult ultrasonically. Here is a rather thickened medial gastrocnemius muscle on the right. Compare it to the normal on the left, and you can see that the muscular strands are lost. And if you take a nice panoramic view, you can see a thickened muscle, and you can actually see some torn strands at the distal end of the medial gastrocnemius. Very nice image quality. My only one complaint is that this medial gastrocnemius was mine, so my own injury. Turning on to breast imaging, where, again, grayscale imaging is paramount. What we have, some extra options on the system to improve your image quality is the correction for speed of sound, quite important when it comes to fatty tissue. And here I'd just like to illustrate this with a patient with gynecomastia, and as the video plays, you can see just changing the speed of sound to optimize your image. So another feature to give you even better grayscale imaging. In this example, you'll see a carcinoma of the breast, and you can see its nice stellate appearance, but when you actually look at such, it's actually a very, very small lesion. If you look at the scale, it's only 5 millimeters, and we're actually getting very, very good resolution here. And in this patient, as we scan further, there was another further satellite lesion adjacent to it. And I'd like to illustrate in this example of a different scanner, a different manufacturer scanner, where I was scanning through an area in the upper outer quadrant of the breast where I wasn't entirely sure whether this was a real lesion, was it a fibroadenoma. And when I put the beta 18 megahertz probe of the Toshiba on it, you can actually see that you make out these tiny little cysts within a slightly grayer area where there's fibroglandular change, and I could make the confident diagnosis of fibrocystic change and avoid the need for biopsy of this abnormal-looking area. But what about other small parts? Here is a soft tissue, well-rounded lesion, and this is in the forearm, and if you look, it seems in continuity with this structure here, which, as we followed it, turned out to be the ulnar nerve. It is highly vascular, and we can make a confident diagnosis that this is a ulnar nerve schwannoma. Get a patient with melanoma, you can see at very, very small lesions here, 5 millimeters, you're getting very, very good detail, but also with advanced dynamic flow, you get a very good appreciation of how vascular these lesions actually are. The thyroid colloid cyst is very well depicted here in the right lobe of the thyroid gland. Look at how clean the margins are. But with denser tumors, such as this Wharton's tumor in the parotid, you're actually getting very good penetration behind this dense tumor itself. And this is a very large lymph node, and when you look more closely, you can actually look at the internal structures. You're beginning to see some of it in this markedly enlarged, inflamed lymph node showing the vascularity. It turned out to be a TB lymph node. Turning on to Doppler, one other feature of Doppler that's improved is that now it's overlaid on a BMO image with precision, and here is just an example of flow within a normal femoral vein, but it's very useful when in this thrombosed right subclavian vein, where you not only see no Doppler flow, but you can actually make out the thrombus within it very, very nicely. One other new feature is something called the vascularity index, and it may have some uses. For example, in this patient with a very vascular breast cancer, you can actually dim the background to highlight the microvasculature a little bit more. So it just highlights, showing you the neuroangiogenic vessels a little bit more in detail. And perhaps if you have it in twin view, you can actually see it much more clearly. And there is also now a tool that you can actually quantify how much vascularity there is. It counts the number of color pixels there is and also works out the number of pixels in your region of interest and provides you with a ratio. Of course, there's still a work in progress. We'd like to see this vascularity assessment in 3D. But it can also be applied to other parts of the body. For example, this thickened mid-Achilles tendinopathy, these are typically very, very vascular. And you can see here there is a feeding vessel into this thickened area, marked vascularity. And the neuroangiogenic vessels around this become more apparent when you dim the background. And you can actually calculate how much vascularity it is. We can actually these are actually very, very difficult to treat, and perhaps looking at the vascularity of these lesions may allow us to subselect patients for what we call high-volume injection into the retroachilles space to try and compress these vessels. And this is what happened with this patient who's had this for over 2 years, and we injected 50 mils of normal saline and local anesthetic into the retroachilles space, ablating these vessels, and you can see what we call post-stripping. The vascularity has all gone. So perhaps some clinical applications there for you in treatment. One other area that we could also utilize this is in patients with rheumatoid arthritis, where for a long time there's marked activity in this marked synovial thickening and synovitis in this left lateral ankle joint. And actually, you can actually then quantify this vascularity and assess treatment a bit more accurately. One sort of slight downside of this at the moment, and I'm sure it's coming, is that the regions of interest you can draw around it are only set to 3, but hopefully I'm sure we'll be able to actually depict our own region of interest more accurately and calculate it in 3D. Now, no premium M system is complete without elastography, and elastography is now in real time, and it's a nice feature to have the curve, the sine wave curve down there to ensure that you've got good and reproducible compression and decompression, and you're still on the lesion itself. But also now you can actually calculate the strain ratio very quickly and in real time. You just place two regions of interest around the adjacent tissue, and we know this is a breast cancer. You can see a very high strain ratio of approximately 10. But contrast this to a benign lesion within the breast. You have a strain ratio of approaching 1 here, and this just turned out to be fatty necrosis. It's also been mooted that strain gives you a larger footprint of how big a tumor is. This looks very small, but when you actually look at the strain footprint, it actually extends quite a bit further. So one of the other areas is looking at the tumor extent with elastography. One novel way, perhaps, in this patient with a breast abscess is that it actually tells you which areas are soft and perhaps the areas which you should direct your needle to if you want a successful aspiration of this abscess itself. But people have also utilized other areas, elastography in other areas, for example, in this tendinopathy in tendons itself, by looking to see whether they're fibrosed over or whether they're soft, and in this case, a Achilles tendinopathy again, which is very soft, perhaps suggesting that may be amenable to further treatment. And here it gives a soft strain ratio. But this is also applicable to other parts of the body and not only small parts, and I digress slightly that elastography within the liver is very important and being shown to have great use in characterizing chronic liver disease. Here I just wanted to show you an example of normal liver tissue and a more fibrous tissue, and this turned out to be focal nodular hyperplasia. So some areas of other parts of the body that elastography is finding its application. Turning to Micropure, and it is a technique which is actually unique to Toshiba, where the background is actually dimmed and what calcification is highlighted, making it more apparent. So one, as a breast radiologist, what is difficult is actually finding these microcalcific foci on ultrasound. Here's an example. You see there's a slight twinkle in this breast cancer itself. Probably you wouldn't appreciate that on the grayscale itself. But it's not here to replace mammography, but what it could add, and I'd like to just illustrate this with this example of a patient with a wide local excision for breast cancer and who developed some dystrophic calcification here within the scar itself. Put the ultrasound probe on, really couldn't see these microcalcifications, turned on Micropure, you got a couple of twinkles, perhaps those were the microcalcific foci, so we tried to biopsy these with the help of Micropure, and lo and behold, we got some microcalcification in that area. So perhaps it's useful in helping you biopsy. We all prefer to biopsy this way rather than go to stereotactic biopsy, and more comfortable for the patient as well. Contrast-enhanced ultrasound, well established in abdominal imaging, but it's even improved on the A500 now in high frequency. I'd just like to show you how beautifully the microvasculature of this breast cancer is depicted in real time. Here you go, the inflow, and look at the network mesh of abnormal vessels. Perhaps this area is not enhancing, maybe due to an area of necrosis, but you can actually also depict the network mesh of vessels with microflow imaging. You could look at other parts of the body, and I draw your attention to the AFSAM guideline, which has been updated for other parts and uses. This is a multinodular thyroid gland, and we just wanted to see whether it all enhanced homogeneously and that there was no hypervascular lesion. And you can see very uniform, homogeneous enhancement of the whole thyroid gland. One other area in small parts which microbubbles are coming into its own, and I've borrowed this clip from Dr. Seaver, where you actually inject around, for instance, a breast tumor to look for the sentinel nodes. So microbubbles have been injected around the tumor itself, and you have to try and trace the lymphatics. And here you go, the arrow will appear, and it is just following this vessel, or this lymphatic here, towards its sentinel node, which has also taken up here microbubbles. So here it is with the grayscale overlay. You can actually see the sentinel node, which has also taken up contrast. One other application which has been around for a while, but also useful, is 3D and 4D And in particular with the breast, for example, what looks like a very small breast tumor, you actually see the finger-like extensions and retraction better in the coronal plane, so it's probably a larger tumor than you first envisaged on grayscale imaging. And here's an example that we looked very small, but we saw the finger-like instructions on the coronal image, and it corroborates with the MRI findings itself. Of course, tumor volumes can be calculated more accurately with volumes and also lead to better assessment for response to treatment. Moving on, there's one new technique with it is that with your 4D or 3D data, where there is a viscous or hollow structure, you can actually follow it and fly through it just like you do in colonography. And this is just an example of the dilated breast duct as we're just flying through it. Perhaps its application may come in looking for subtle intraductal lesions and maybe aid the surgery. One thing I'd like to mention is that we've seen many examples of fusion for abdominal, and I'm sure it's coming again for small parts, which are particularly useful in breast imaging. But I'd just like to highlight our experience with fusion. It's actually very easy. The synchronization of the CT image to liver is very straightforward, takes a matter of a few steps. But instead of, we don't do any intervention, but we found this very useful, in particular detecting those tiny liver lesions in staging scans where you can barely find. They're 2 or 3 millimeters on the CT scan. You can very rarely find them on ultrasound without the help of where it is on the CT scan. And this is just an example of a patient with breast cancer. We couldn't find these lesions without the help of the CT fusion. Here it is, and it just turned out to be a cyst. So these can be very helpful in a diagnostic setting as well, not just only in intervention. You can see in real time there is no loss of temporal resolution at all, and lots of tiny, tiny cysts which we found difficult to see without the synchronization. So really that was a whistle-stop through all the new techniques available on the A500. But one key thing I find is that it does the fundamentals very well, and it's really a step up. Grayscale imaging, particularly with the 18 megahertz probe, and the new compounding and precision really provide exquisite image quality and very helpful in MSK breast and of course other small parts. And this is without loss of frame rate and has very good penetration. Doppler is very nice, being able to see a better B-mode image. And together, actually, with these two, in a clinical setting, you probably get to a confident diagnosis in more than 90% of cases. But you also have the icing of the cake, the other techniques which I think just add and help you with your diagnosis, the vascularity index and the background display, perhaps in 3D, and with different ROIs, we're able to look at tumor response and also in synovitis response. Contrast-enhanced ultrasound, much more improved and increased sensitivity and homogeneity in the near field now, looking at vascular enhancement of other lesions, but maybe coming into its fore with sentinel node detection, and I just draw your attention to this paper by Dr. Seaver. Elastography in real time, been shown to distinguish benign from malignant breast lesions, but we know that its applications are not only now confined to the breast, particularly we can use it in the thyroid, the prostate, tendons, and the liver, and perhaps all this may help you in assessing tumor size and also appropriate site to biopsy, particularly in the prostate gland. Fusion, very exciting, but perhaps not only used for RFA treatment, but also detecting and categorizing lesions which you find difficult to find without the aid of fusion that was so small on CT scan. But what we're really looking forward to is fusion with MRI scan for the breast, and we've seen it in the prostate, which will have huge clinical benefits, but is particularly challenging. So, and we have other tools which are put in the research category, such as ASQ, which we've had no time to talk about, particularly looking at characterizing chronic liver disease. Micropure is still available, and perhaps large studies should go underway to look and see whether they will aid breast biopsies in detecting microcalcification. And of course, we've got tumor volumes and 4D and fly-through, which are very interesting techniques, but yet to find its clinical application. So, with all that, the future's looking very bright for advanced ultrasound techniques, particularly with small part and high frequency imaging. Just like to show you a picture of where we did all this investigations with the A500, that's Charing Cross Hospital, on a day where it's not raining for a change. And I'd just like to say thank you to my colleague David Cosgrove and all the Toshiba medical systems in Japan, Europe, and in the UK. And finally, some of you may remember this clip before, but future advances. And this is just a fun video for you to enjoy at the end of a very long afternoon. Thank you very much for your attention.
Okay.